gout, very important topic. Now, when it comes to gout, it's an acute inflammatory monoarthritis, right? So it's a problem with the precipitation of monosodium urate. That's the first thing to learn. They're accumulating monosodium urate. Risk factors: male, hypertension, obesity, diabetes, dyslipidemia, alcohol, all of those. But the strongest risk factor is hyperuricemia. That means having a higher uric acid, folks, okay? Now, there are two ways you could get high uric acid. One, overproduction or under excretion. If you see, under excretion is the main one. 90% of the time people have hyperuricemia because they are not excreting, folks, okay? Probably renal failure or anything, or alcohol exacerbation, all those things can do that, folks, okay? Now, overproduction of uric acid is only about 10% of the people. If you remember tumor lysis syndrome, we talked about it. One of the other complications is production of uric acids and stuff, okay? So that's that. And also von Guericke disease has increased uric acid too. So those are two main reasons for people to get increased uric acid. The next thing what you need to know, when we do those crystals, these are needle shape with negative bifringent under polarized light. You have to know that. And you also have to know it's yellow under parallel light and blue under perpendicular light. I know it's level 2, but they are asking that too. You need to know that. Okay, so that's the finding of gout. Now let's take a look at the symptom of gout. Now it is asymmetric joint distribution. They have a joint is swollen, red and painful. Classic manifestation is painful MTP joint, which is your big toe we call podagra, folks, okay? And they also have this, look at this option, picture C here, it's called tophus formation, folks. These are accumulation of uric acid underneath the skin. If you actually cut it, you could see it's all coming out, uric acid comes out, folks, okay? Now, it can happen anywhere. Usually, acute attack tend to occur after a large meal and food rich in purines because these produces more uric acid and alcohol consumption. People with gout, we tell them they cannot drink alcohol. Why is that? Because alcohol and gout, uric acid, they both are excreted through the kidney with the same receptor. So when we drink alcohol, the kidney prefer to excrete the alcohol and they don't excrete uric acid. So the uric acid backs up in the blood and they accumulate. Does that make sense, folks? So that's the reason, okay? You could see it here. That's the idea. So that's gout. Treatment for acute attack, we give NSAID, steroid, or colchicine. What's the mechanism of action of colchicine? It inhibits microtubules, okay? Similar to Shediac-Higashi syndrome, that's where we talked about this, right? So that's that. And the chronic treatment, that means in between prophylaxis, xanthine oxidase inhibitor, allopurinol, and febuxostat. We'll still talk in the pharmacology. Now, I want to put gout also here in the 2,000 to 25,000 because still is an inflammation, folks, inflammatory, okay? That's inflammation. Are we clear with gout? Okay. Next. Calcium pyrophosphate deposition. We used to call this pseudo gout. Okay, so the gout is monosodium urate. This one is calcium pyrophosphate. Is everybody clear, folks? So that's the one. Deposition of calcium pyrophosphate crystal within the joint space. Occurs in patients, elderly people. And here, more commonly, if you see pain and swelling with acute inflammation, chronic degeneration of that, most commonly affected joint is the knee, okay? Knee joint is affected almost like arthritis. Here, what happened, all those cartilage in the joint become calcified. When the calcium deposit in the cartilage, we call that chondrocalcinosis, okay? So calcium deposition, folks, okay? These crystals are rhomboid and weakly positive bifringent under polarized light. You need to know that. Okay, this is the weakly positive. Treatment is pretty much same. If you see acute NSAID, colchicine, and steroid prophylaxis, also colchicine. Now I'll put pseudo-gout also here. It's all inflammatory at the end, folks. Okay, it is inflammatory. So continuing this. Okay, now before I do the top disease, I just want to go and do the septic arthritis quickly. Now, what does septic means? Infection. Okay, the minute we say septic arthritis, the joint is infected. The joint is infected. The minute your joint is infected, all the WBC want to come in there. Look at the synovial fluid, more than 50,000. So here, the one and only disease we want to talk is your septic arthritis. So when you are doing a question, your eye should scan that synovial cells, and if it is more than 50,000, you jump to septic arthritis, folks. Okay, that is the only disease. Look at that. Okay. Now, Staph aureus or Strep or Neisseria, any of those can cause. Usually unilateral, right? Because whatever the joint is infected. Treatment, antibiotic, aspiration, and drainage. You have to drain. Sometimes disseminated gonococcal infection. So it's another septic arthritis that's with the sexually active people with STI. Okay, same thing with a different organism, folks. So that's septic arthritis. So that chart is helpful in the questions. Any questions so far? No. Okay. Now, so that's septic arthritis. Now let's see here some other disease. Systemic juvenile idiopathic arthritis. Systemic arthritis seen in younger people usually presents with daily spiking fever, salmon pink rash, arthritis associated with anterior uveitis, frequently presents with leukocytosis, thrombocytosis, anemia, all of them. And look at the treatment. Isn't it the same treatment as rheumatoid arthritis? And also that sounds like rheumatoid arthritis, isn't it, folks? So when rheumatoid arthritis happens in the pediatrics, we call this systemic juvenile idiopathic arthritis. So in another word for it is juvenile rheumatoid arthritis. Okay, so that's the same disease, but it happens in the kids, so we have a different name. So that is that. Next, Sjogren's syndrome. To understand this, it is an autoimmune disease that's attacking exocrine gland. What are exocrine glands? These are your lacrimal gland, salivary gland, and all those things, right? Now, if you see, lacrimal and salivary glands are affected. Where is lacrimal gland? Lacrimal gland that produces tears. Here or here? It's here. Okay, because you know why? The tear is produced laterally, so the tear comes towards medial and then get drained with lacrimal duct. So this is lacrimal gland, this is lacrimal duct. Does that make sense, folks? You know, have you noticed every time you cry, you get a stuffy nose after that, right? Because all the tears is going this way. Try it after class today, right? How do you cry? All you have to do is take NBME 26. I'm just kidding. You will automatically. Now, the idea is that's lacrimal gland, okay, on the side. That's that. All right. Now, so that's get attacked. So they also have some inflammation of the joint, okay? That's why they are bringing that topic in here. Keratoconjunctivitis sicca, so that's the idea. Here, there is no tear production. So what's the function of tears? It gives the moisture of the cornea, isn't it, folks? Now there is no tear, people get corneal damage, actually, okay? And sometimes they even get ulcer. That means there will be a hole in there, okay? So that's that. Xerostomia, no saliva production, so they have a dry mouth. Presence of some antibodies. These are anti-A and anti-B antibodies, folks. Bilateral parotid enlargements. So that Sjogren's syndrome. folks. Okay. Now there's a lot of lymphocytic infiltration. So let me highlight that. If you have a lymphocytic infiltration, there's a chance to get lymphoma. That's what they are trying to tell here, folks. Okay. Chance to get lymphoma and stuff. But the only way to confirm this diagnosis is to do a biopsy. You have to do a gland biopsy to confirm. This topic is kind of overused for a long time. So it's going down, but you should know the basics. What is Sjogren's syndrome is, folks. Okay. Let's go to this one. Super high yield. There's 4 diseases in here. These diseases are called seronegative spondyloarthropathies, right? What does seronegative means here? Now, remember, when we studied rheumatoid arthritis, there was a rheumatic factor, isn't it, folks? What is rheumatic factor? It is an antibody. That's which type of antibody? IgM? IgG, right? So that is the rheumatic factor. But in this disease, there is no rheumatic factor. That's why it says arthritis without rheumatic factor. Is everybody clear, folks? Because it's negative for rheumatic factor, we call it seronegative, because in the serum, there is negative for rheumatic factor. Is everybody clear, folks? All right. This is few diseases. Let's take a look at this one. First, psoriatic arthritis. Nobody can miss this question because why? These people will also have skin psoriasis, right? So they will give enough information associated with skin psoriasis, nail lesions, asymmetric and patchy involvement. Look at the picture, folks. You know, that's a silvery scale. You could see that, okay? Silvery scale appearance of that. Dactylitis. What is dactylitis? Dactylitis is explained as these patient fingers looks like a sausage. That means it's swollen. It's thick. Okay, it's a sausage shape of finger. I'll show you when we do a question. And that's what it is. Okay, it gives you pencil and cup deformity. You could see the B here. That's that. Now, that's psoriatic arthritis. That's the easiest one because of the skin. Now, look at this one. Ankylosing spondylitis. Number one criteria, it happens in youngsters 20 to 30 years old. If you are reading a question, if the question is more than 50 years old, there is no reason to pick ankylosing spondylitis. It's something else. NBME has it, don't pick that. It has to be very young people, folks, okay, 20s and 30s. Symmetric involvement of the spine and sacroiliac joint. So what is exactly happening in ankylosing spondylitis? Look at this picture, see here. What do you see between those two? Here you are able to differentiate the vertebral bone. Here it's all fused together. You see that, folks? So these people walk around without movement. They cannot breathe in. If you want to breathe in, your chest has to expand, isn't it, folks? In order to expand, your bone has to stretch. These people cannot. They walk without, like they cannot even move. Like they're like a stiff. Because the bones are stiff, all fused, though no flexibility. And there's a joint called sacroiliac joint. That's all the way in the back that connects the sacrum and iliac. That is fused. And there's another joint called costovertebral and costosternal. Where is this? Costosternum means the rib comes to the sternum. That's costosternal joint. On the back, where the rib goes, it's costovertebral. Does that make sense, folks? They are all fused. Imagine there is no mobility. These people cannot stretch their chest, okay? So what happened with that? Now you could see restrictive lung disease. Why restrictive lung disease? Because these people cannot expand. If they cannot expand, can they breathe in? If they cannot breathe in, that's restrictive lung disease. Is everybody clear, folks? That's a restrictive lung disease. So we have to monitor the degree of reduced chest wall expansion. So what type of restrictive lung disease? So let's say in this restrictive lung disease, what happened to AA gradient? Type it up, normal or increased? Come on, folks. You guys have to give me some motivation by answering some questions. Answer, ask yourself, is this intrapulmonary or extrapulmonary? This is extrapulmonary, right? The problem is outside the lungs. If it is extrapulmonary, what happened to AA gradient? It's normal, right? AA gradient is only increase in intrapulmonary when the problem is inside the lungs. So this is extrapulmonary, folks, okay? So normal AA gradient, because there is no problem in gas exchange. Is everybody clear, folks? All right. Look at the most common age, young people, folks, okay? That's ankylosing spondylitis, folks. Next one, inflammatory bowel disease also sometimes have arthritis. It's just a Crohn's ulcerative colitis. Sometimes they could have this spondyloarthropathy. It's not that important. Reactive arthritis. We used to call it Reiter syndrome, right? Can't see, can't pee, can't climb. You see that? That's basically it is, folks, okay? These are all seronegative spondyloarthropathies, folks. Let's see if we have a question on that. So everybody is getting the diagnosis. 64-year-old woman, a man, comes to the emergency department due to acute knee pain. He developed redness, swelling, and severe pain affecting the right knee a day before his arrival. The patient has had 3 similar episodes in the past year that resolved quickly with over-the-counter analgesics. He has a history of polycythemia vera, but has been non-compliant with phlebotomy. Vital signs and cardiac is normal. There's a severe pain with movement at the joint, and the other joints are grossly normal. Needle aspiration of the joint is performed. What you get it? So here you should be fighting between these two, E and G. Agree? So I have both answers, E and G. How do we work this? Let's see, somebody tell me, because this is something that we have not studied. That's why I brought this question. Let's see. Okay, so I'll give you a hint and then you're going to tell me. The answer is E, it's gout. So I want you guys to tell me why it's not pseudo-gout. Because when you read a question, it's a knee and everything is easy to fall for pseudo-gout, isn't it, folks? So the key, you're going to write it next to gout. Patient has a polycythemia vera, that is your myeloproliferative disorder. It's always associated with gout, not pseudo-gout. Okay, now don't write polycythemia vera, write myeloproliferative disorder. How many myeloproliferative disorder do you guys know? Polycythemia vera, essential thrombocythemia, right? And then you have myelofibrosis. Remember those 3 diseases, folks? So they are only associated with gout. That's the only way you could rule out this here, folks, okay? Otherwise, it will go to G if I remove that page. If I remove this polycythemia section, it will go to G. Is everybody clear, folks? That's the only way you get it. So it's okay if you get it wrong, but make sure you write that down next to it, okay? Now, it should be there somewhere. Where is it? Okay, that's the key to differentiate. All right. Diagnosis, please. When you read this question, when you look at it, my eyes scanned this one. Did you guys do the same thing? So the minute is more than 50,000, it's septic arthritis, okay? And then you're gonna go for antibiotic. That is the treatment here, folks, okay? All right. That is what it is, okay? The biopsy won't help you guys, okay? But then the word itself tells you the answer. So when you read this question, the diagnosis should be Sjogren's syndrome. Did we get that? Even if you don't see the biopsy, it says a salivary gland biopsy. Did we study any other disease you do a biopsy of the salivary gland? No. By looking at it, I don't think it does anything. Right? Exactly. So that is a Sjogren's syndrome. What is Sjogren's syndrome? What cell accumulate? Lymphocyte. So not lymphocyte. Lymphocytes, yeah. It is lymphocyte. So that means lymphoma. Does that make sense, folks? There's no any other options that can come closer to that. Okay, so that's that, folks. Right. So that's a lymphocytic infiltrate in germinal center. That's all it is. All right. Now you guys have this. Okay, let's go back here. So what we have done so far, we have completed all the joint diseases. Is that clear, folks? Now the next thing we're going to go is to connective diseases. Okay. Now the first connective disease we're going to talk about is SLE. These are connective tissue disorders. Now, what is connective tissue? Let's talk about it. Our human body has something called main parenchymal cell. That means they are main cell. Like let's take about a brain, for an example. If I ask you which one is the functional unit of the brain, you guys going to say neurons, isn't it, folks? But who's the supporting cells for neurons? Astrocytes. So astrocytes give the support. Same thing in our human body. We have a connective tissue which functions like a supporting tissue. They are not the main organ, but they are everywhere in the human body. So when they get disease in those connective tissue, We call those connective tissue diseases. Number one we're going to talk about is SLE, okay? Systemic lupus erythematosus, folks, okay? Now you could see here, it's a systemic remitting and relapsing autoimmune disease, organ damage primarily due to type 3 hypersensitivity reaction, and also you would have type 2, so both. So type 3 means antigen antibody complex deposit, and then you get attacked, or directly antibody attacks, folks, okay? Associated with deficiency of early complement, okay, we talked about this. Classic presentation, rash, joint pain, and all these things. But if you see on the side, I know you guys know all of them, but I want to highlight this. We did a question on nephritic syndrome or nephrotic, right? Recurrent nasopharyngeal or oral ulcer should ring the bell for SLE, folks. Okay, recurrent, that's important. And look at this, it's painless too. That's something new to learn. If you were to have a different ulcer, it's painful. Okay, it's painful. This is painless, folks. Okay. Now they have rash, arthritis, psoriasis, hematological disorders, renal failure. Most common cause of death in SLE is renal failure because it could be nephrotic or nephritic. Okay. Now, we also studied these people have Liebman-Sack endocarditis. What does that mean? These are called morantic endocarditis, non-infectious endocarditis. We studied that. Non-infectious, lupus nephritis, and then you have nephritic or nephrotic syndrome. It doesn't matter. Most common and severe type is diffuse proliferative, which makes sense. Nephritic syndromes are the most severe one, folks. Are we clear? All right. Common cause of death in SLE, renal disease, folks. And then people can get infection, cardiovascular, any organ can involve, but the most common is. Now, antibody. Look at this. Anti-SSA positive in pregnant patient increase the risk of newborn developing neonatal lupus, folks. They could have some cardiac block, perioral diffuse rash, and all these things. Okay. Now that's that. So these are symptoms. I don't think anybody will miss that. Let's pay attention to these antibodies. The most specific antibody, anti-double-stranded DNA antibodies. Okay. But what if I tell the patient has drug-induced SLE? You guys know the medication. There are some medications that can cause. What antibody do you look for drug-induced SLE? It's not the same anti-double-stranded. What is it? Anti-histone antibodies. Anti-histone antibodies. So the minute you see anti-histone antibody, that should be a drug-induced, okay? Not there. Okay. So that's your systemic lupus erythematosus. There's another type called mixed connective tissue diseases. These are features of SLE and some systemic sclerosis. Sclerosis means fibrosis, and polymyositis. We'll talk about that as a subcategory. Now, after this, I want to talk about antiphospholipid syndrome. Now, what is antiphospholipid syndrome? People with SLE, they are forming thrombosis. That's a stress. So that's the basic here. All these people are getting a clot. It could be primary or secondary autoimmune disease. Diagnosed based on clinical criteria. Thrombosis. So what will be the symptom? If you read a question, if the question says this particular lady had multiple abortions on the first or second trimester, it is an antiphospholipid syndrome. Because why? Every time they become pregnant, they create a clot in the abdominal, which carries the oxygenated blood. So multiple abortions. Okay, that's the idea here. We have to keep they will have a lupus problem. And cardiology, all these are finding, and we need to give systemic anticoagulation. We need to prevent the clots. Now, these people give a false positive syphilis test. Like if you see CPR or RPR, these are syphilis tests. But people with this disease, you get a false positive. Now, the lupus anticoagulant can cause prolonged PTT. Simple. They can easily because it's all infant attack. Does that make sense? That's all. It is not a correct equation of normal plasma. It doesn't matter what you have, as long as you have blood cells and different prolonged PTT. Okay. That's basically it. That's your necessity. Now let's continue. Polymyalgia rheumatica. These are very important diseases. It's a good that they put both next to each other. Now, polymyalgia rheumatica is the pain and stiffness and proximal muscles. If I ask you, which is my proximal muscle anything that goes my head is proximal, the clips. So here, these people come with two types of symptoms. Their shoulder and hip. That's it. Pain, shoulder and hip. Okay. Shoulder and hip. Often fever, malaria, weight loss. It does not cause muscle weakness or anything. Now, sometimes people with polymyalgia also have giant cell arthritis. These are blood vessels disorder. Now, we need to kind of step back here and talk. You should write this and make it on the bottom. Okay, so you should write. Now, giant cell arthritis is also known as temporal arthritis, isn't it, folks? Okay, so I'm going to write temporal arthritis. We'll talk about this. Temporal arthritis will always have polymyalgia rheumatica. They will always have polymyalgia rheumatica. Okay. So people can develop temporal arthritis and polymyalgia rheumatica together, or they just get polymyalgia rheumatica alone. It's a great feat, folks. Now, if they develop polymyalgia rheumatica alone, you give them a low dose steroid. That's the treatment. The treatment is low dose steroid. That's for polymyalgia rheumatica alone. If they have both giant cell and polymyalgia rheumatica, it's a high dose steroid. This is a very question. So when you read a question, if you need to focus and make sure if the patient has polymyalgia rheumatica alone, or do they even have temporal arthritis? How do you know that you only want a headache added to it? A headache and some complication, right? So that's everybody clear? Now if you look at polymyalgia rheumatica, look at that. Low dose, right? That's low dose. But I will also write here polymyalgia rheumatica plus temporal arthritis, then high dose. Don't forget that. It's very easy to miss that. So that's polymyalgia rheumatica. Here. Okay. Now next, I also want you guys to highlight here normal creatinine kinase, because it does not affect the muscle. That's important. That doesn't destroy the muscles. I'll tell you why I highlighted. Now, next disease, fibromyalgia. Fibromyalgia, it's actually a psychiatric disease. It's treated by psychiatrists and sometimes rheumatologists. What's the problem with fibromyalgia? There's about 18 locations in the body. They will have pain and tenderness in 11 locations. Okay, so you don't have to know all the 18 locations, folks. But the key to see, they will have shoulder, hip, and more places. Why am I saying this? If you read a question, if there is only shoulder and hip, then it's polymyalgia rheumatica. Shoulder, hip, and more places than fibromyalgia. That's the clear, folks. Now you can see common in youngsters, widespread musculoskeletal pain associated with tender points, stiffness, and all these things, folks. Okay. They also have a cognitive disturbances we call fibro-fog, normal inflammatory markers and stuff. Okay, so that's fibromyalgia. Regular exercise, antidepressants, all these things. They usually take antidepressants and they live with that. So if you see their history, they're like 20 years of antidepressants and stuff, so they have to take that. That's fibromyalgia. So this is one of the diseases you cannot prove whether they have it or not. They could come and literally lie. All those 11 locations that you have pain, there is no way to prove that you don't have fibromyalgia. Is that clear, folks? Why? Because there's no lab value to confirm that. So that's fibromyalgia. Next one, polymyositis. Okay. Now, polymyositis and dermatomyositis is exactly the same disease, but one involves the skin, the dermatomes, the other one don't involve the skin. Okay. I need to show you some anatomy. Because it's a connective tissue. Okay, can you guys see the picture? This is a muscle. Okay, so let's say we take the whole muscle and then we pull one bundle. In one bundle, we pull one fiber out. Okay, now there's a fiber. Around the fiber, there's a connective tissue, what we call endomysium. Endomysium is a connective tissue that covers the muscle fiber. Then we have another one we call perimysium that covers multiple fibers together. Do you see that, folks? Multiple. So technically, I could put my arrow here. That is endomysium. You guys see that? And then bundle perimysium. Then a couple of bundles, the bigger one outside, that's epimysium. So it's endo, peri, epi. That's the order from inside to outside. Is that clear, folks? Same connective tissue present in the nerves, but the name changes. Endoneurium, perineurium, epineurium. Only the last word changes. Instead of mysium, it's neurium. Is everybody clear, folks? All right. So that's something you need to know. Now, if you see here, polymyositis is a progressive symmetric proximal muscle weakness characterized by endomysial inflammation with CD8. You see, endomysium, that means all the way in. Is that clear, folks? All the way in. Okay. I always write next to it so you don't miss. Endo, peri, and then epi. So you know this is inside. So that's outside. That's the order, folks. Okay. So polymyositis is an inflammation of the endomysium. Are we clear with this? All right. And CD8. Now, if you see the dermatomyositis, it's very similar to polymyositis, but involve the skin. Gottron papules. You could see the picture. Then they have a facial erythema, rash, all of them. You could see that. So what is the problem here? This is a perimysial inflammation with CD4. So it's very hard to remember. First one, endomysium and CD8. This is a perimysium and CD4. You have to remember. At least we know there's nothing involving epi. Is that clear, folks? So that's endo and peri. Okay. Now, if you see some common features, highlight, increase CK, creatinine kinase from muscles. Because why? Polymyositis also come with the shoulder pain and hip pain, exactly same as polymyalgia rheumatica. The only difference you could differentiate polymyositis and polymyalgia rheumatica. Polymyalgia rheumatica has normal CK. This one has increased CK. You see that, folks? One and only differentiating factor. One and only differentiating factor. Yeah.
Does fibromyalgia have anything to do with the CK?
No. Okay. Now, myositis ossificans. Where did I mention this word? That's your last question for the day. Tell me, where did I mention myositis ossificans? Okay. On the first day of our class in pathology, I mentioned, right? Where, what topic, under what heading we were talking about this? Metaplasia. I said an example, a muscle tissue is being replaced by a bony after a trauma. Did I say that? That's what this is. And at that time I said it, they actually cover on musculoskeletal when I talk about it, right? Here we are. It's a heterotropic ossification involving skeletal muscle associated with blunt muscle trauma, presents as a painful soft tissue mass. Okay, that's the idea. Eggshell calcification. It's a metaplastic bone surrounding area. That's the idea here, folks. Okay, so it's literally a piece of your muscle become bone. That's why the myocyte is muscle become ossific, and ossific can mean bone, muscle become bones, folks. Okay, is everybody clear, folks? All right. You know, it's not me, I wanted to ask question, but when I see some words, I'm like so itchy to ask that. So to make sure you guys, right? So that tells you, tell me the disease we studied in lungs that has eggshell calcification. Hilar lymph node eggshell calcification. We did a question and they were only able to answer that question by picking that. It's one of the pneumoconiosis. Not sarcoidosis. Sarcoidosis has bilateral hilar lymphadenopathy. Okay. Silicosis. Silicosis. Okay. That's that. Okay, very good. So that's that. Now, if you go back, that concludes your connective tissues, folks. Okay, that's pretty much. Now, tomorrow, we're going to talk about bone, skin. Of course, there's a blood vessel disorder. We're going to finish it up tomorrow with musculoskeletal. Today's job is to review what we have done and keep it simple and don't get tired. Okay, we have neuro coming in. Okay. All right. Whoever I ask you to stay back, stay. Everybody else, I'll see you guys tomorrow.
Thank you so much. Have a good day.
You too. Bye.
Thank you.